Good morning. It's great to be here. I want to thank Dr. Eisman and Moto for inviting me to speak to you today. It's a great honor. But it is time for me to go home because my liver needs a break. All those therapists do is drink beer, wine, caparina, too much. So I will be speaking about scapular muscle examination algorithm. And the purpose is really to discuss this algorithm when we have significant scapular dyskinesis. And then also looking at the implications toward diagnostic accuracy. So if we see significant scapular dyskinesis, it will fall into 4 different categories. One is a long thoracic nerve palsy, spinal accessory nerve palsy, a motor control problem, or something that is not either of the, or all of those, something other like a scapular muscle detachment, a syrinx, or multifocal motor neuropathy. So static muscle function, what does it do? It holds, the scapular muscles hold the shoulder girdle in an elevated and a retracted state. Here is an individual who's 11 years post spinal accessory nerve palsy. The scapula is in a downward abducted position because she does not have a trapezius. There are other abnormalities that will cause static abnormalities, such as an osteochondroma. The most common reason someone will have a static medial winging, or apparently there's significant asymmetry, is a scoliosis. That's all you need to do is have the person bend forward. They have a rib hump. You have a flat bone on a curved surface. It looks differently, and it actually moves differently. It has nothing to do with their problem, though. Dynamically, scapular muscles upwardly rotate, posteriorly tilt, and externally rotate the scapula. You were probably told about medial winging occurring with a long thoracic nerve palsy, lateral winging occurring with a spinal accessory nerve palsy. That was on your boards. It's an absolute myth. Lateral winging does not occur. And we have seen this now when we look at three-dimensional telemetry and we track individuals who have spinal accessory nerve palsies. What occurs with spinal accessory nerve palsy is internal rotation, not external rotation, which would be required with lateral winging. So that is a myth. You should have gotten that one wrong on your test back then. Scapular muscle mechanics, if you think about it, basically, if we simplify it, the serratus anterior works in the sagittal plane. So when you examine someone in the sagittal plane, you are biasing that examination to the serratus anterior. If you're going to look into the coronal plane, watch the scapula, it has to adduct. So the trapezius primarily works in the coronal plane. And we're going to use this when we go through our algorithm. A mention about electrodiagnostic studies. Rarely is a full nerve conduction study done. Typically, practitioners do not do a nerve conduction study on the long thoracic and spinal accessory nerve. Rarely do they ever needle the lower and middle trapezius. You know it's a technically demanding procedure, but very difficult on an atrophied muscle. Operator dependent, and Bigliani reported that 50% of spinal accessory nerve palsy cases had incomplete testing or were misdiagnosed. Now, dyskinesis literature, there's a lot of stuff out there on scapular dyskinesis. The bottom line is, the best we can do as far as reliability, if we, 5 of us, were to look at someone who we thought had scapular dyskinesis, is to say, yep, that is absolutely something wrong with that shoulder blade, or I don't know, maybe, maybe not. So when there's absolutely something wrong with it, what causes it? And that's what the algorithm does. Now, I'm going to go through this using a lot of video on different patients, but the bottom line is you assess range of motion. If they have dyskinesis, you then move on to these tests, and each one I will go through. The first 3 are related to the long thoracic nerve palsy, in particular this plus sign, which we'll see. The flip sign is absolutely only occurs with a spinal accessory nerve palsy, and that's been put in the literature. If all of these are negative, we then go down and we try to eliminate the dyskinesis because it's a motor control problem. If you can eliminate it, then it's a motor control problem. Of course, we have this other causes will then look like long thoracic nerve, spinal accessory nerve, or motor control. This is an individual who was sent to me. He's 6 weeks post anterior dislocation. He also had a long thoracic nerve palsy that was misdiagnosed. This individual had a first rib resection. If you want to see beautiful compensation of the lower trapezius, he has a long thoracic nerve palsy. On the way down is when you'll see the medial winging, mostly because the trapezius turns off at that point in time. If we look at coronal plane motion, looks pretty good until the end because he doesn't have a serratus. He has painless weakness, and that is what happens with these individuals. This individual doesn't really have what looks like medial winging. He has limited motion. He was sent to me with a SLAP lesion, but he also has a long thoracic nerve palsy. We're going to see him later on. Coronal plane motion looks pretty good. Again, he doesn't have full motion. This would deceive you relative to his scapula. This woman is 3 years post radical neck dissection. She does not have a trapezius. She has very good sagittal plane motion because the serratus is present there, but no one I have ever seen, and I have probably seen over 80 spinal accessory nerve palsies, can elevate their arm in the coronal plane. You can see the rhomboid attempting to work, levator scapula, but they cannot mechanically move because the trapezius is not there. Now this next gentleman, I wish I could, he's the last. This individual was sent to me 15 years ago, had a long thoracic nerve palsy. She has significant dyskinesis. She's had 2 surgical procedures for impingement. She's ready to get another one. The doc sent her to me. We sent her for an EMG. It's negative for the long thoracic nerve. We'll see her a little bit later on. This gentleman, anytime you see significant bilateral, significant winging, you have to think there's something wrong and it's above the neck. So this individual actually was going to Boston. He stopped in Philadelphia to see our surgeons. He was going to get his right scapula fused to his thoracic wall. We put him through the algorithm. He had absolutely nothing wrong with his serratus anterior. He had 2 EMGs that were positive. His problem was supratentorial, above the neck. This is an individual who had her partial lung resection. This is now the first test you would use in the algorithm. It's called the serratus anterior isolation. You have the person protract and slightly elevate. That's what the serratus anterior does. And you can see on the right side, it's normal. She cannot fully protract, can't really get it out more than half of the way. And then we give resistance, and I can easily displace that scapula into retraction. You should not be able to do that in an intact neural system. This individual I saw for a massive cuff tear, anterior dislocation. He also had a long thoracic nerve palsy, was not diagnosed. Sent him for 2 EMGs. They were both negative. You cannot trust EMGs. You can see he can protract this side. He cannot protract this side, and I can easily displace that scapular border. He does not have a functioning long thoracic nerve. This individual was sent to me with a long thoracic nerve palsy diagnosis. It was correct. Again, a nice example of positive serratus anterior isolation. Cannot do it, and I can easily displace that scapula backwards. Here's our friend who had the SLAP lesion. This is a plus sign. This is a great test. Just use it. It's very clinically simple to do. Not impressive winging, but when we have him reach forward, when we have him do what we call a plus, he protracts the scapula. Now what happens is the trapezius turns off. And if you take a view from the side here, that's significant medial winging because it takes away the trapezius. He was sent for an EMG positive. This young lady I saw, she was a bodybuilder. I think maybe she needs a little bit more work on that. But she had about 1 week of discomfort. She has the best substitution I've ever seen. It is her left shoulder. You cannot see any medial wing. You can't really see much asymmetry relative to the trapezius. But when we have her do the plus sign, it's absolutely positive. We sent her for an EMG. It was positive. This is a great test to use. If it's in, they only have it. This individual was sent to me who had a history of a long thoracic nerve palsy. Then it recurred. The doc did a neurolysis of the long thoracic nerve. Didn't like the way it looked postoperatively. I know the surgeon, he sent him to me. Indeed, he has a long thoracic nerve palsy. He has a positive plus sign. We're going to see him later on because he has an unusual presentation. Okay, now we go to the flip side. I put this in the literature in 2008. It is the only thing, when it's present, the only thing it is a spinal accessory nerve palsy. And what the flip sign is medial winging, but it's produced by resisted external rotation. So all you do is resist external rotation with the arm at the side, and what happens, you notice the medial border comes off because the middle and lower trapezius are not there. It cannot hold the medial border down. The rhomboid does not function in this position. The rhomboid is not much of a player, in my opinion, in the shoulder. This is rhomboid minor. That often does activate. This next individual is unusual in the sense that he does have rhomboid compensation. That is not typical. He was sent to me with impingement. He had it for over 6 months. Again, they usually start with a painful 1 to 2 week period, and then the pain goes away. He actually did develop subacromial pain. That's a positive flip sign. That's the rhomboid trying to activate. Totally abnormal position. Here's our friend who had the lysis of the long thoracic nerve. He also has a positive flip sign. He actually has a long thoracic nerve palsy and a spinal accessory nerve palsy. Very unusual to see, but we're going to see that in a little bit. Now, flip side, why does it work? Well, we think it works because, or it occurs because the arm is at the side, the posterior deltoid and infraspinatus pull from their insertion, and they lift that medial border away because there is no middle or lower trapezius present to hold the medial border on. The rhomboid does not work in 95% of the cases. Now, let's say we go through our algorithm, everything is negative, they still have what we think is dyskinesis. Okay, now can we fix it? So this is a young man who has an unusual motor pattern. He actually is subluxing posteriorly in his shoulder. He's got this jerky motion, turning on the serratus anterior off, and I believe he's using his pectoralis minor. I think that's what many of these individuals who have a history of instability do. So can we fix it? So this is within minutes of that last video. I have him externally rotate. External rotation stabilizes the joint, and then I make him use his serratus by keeping the shoulder up and forward. And you can see now all that jerky motion is gone. He has a motor control problem and actually was fixed within a week. Here's our friend who had a history of a long thoracic nerve palsy. She has impingement, again, pretty significant scapular dyskinesis. Can we fix it? So again, we make her use her serratus. Many people have this pattern of trying to drop the scapula down. I think they use the pectoralis minor. I'm giving her tactile and verbal cues to keep the shoulder blade up. And you can see now on the way back down, all that dyskinesis that we saw, it goes away. She just doesn't know how to use her serratus anterior. It's like a virus in the neuromotor pattern, and we make it go away. This is an individual I just saw about 4 weeks ago. She had an instability event first time. She's hyperlax, multidirectional instability. When she relaxes, she subluxes. Watch her scapula. That is not a passive motion. She activated her pectoralis minor. So when we look from the front, and that actually dumps out the humeral head. She subluxed. She's going to manually reduce herself. And now I'm going to make her use her serratus anterior. That will keep the head in because she doesn't actively use her pectoralis minor to dump out that humeral head, and she can begin to move. And this is how we treat patients initially, just with simple motor patterns. It is a motor control issue, and all you have to do is kind of magnify that, reteach the patient how to do it. This individual I saw after about 3 months, he woke up one day. He said he had a lot of pain in his shoulder blade region. He couldn't move his arm. It was very weak. The doc sent him to me with a long thoracic nerve palsy. He does have that, but he also has a spinal accessory nerve palsy. Again, very unusual. So you can see dramatic winging in the sagittal plane. If we put him in the coronal plane, if he had a trapezius, the scapula would lock back on. And again, there is no trapezius. Sent him for an EMG. That was positive. Here he is 1 year later. He saw me about 8 weeks or 8 weeks previously. He woke up, he couldn't bend his elbow or extend his wrist. He was finally diagnosed as having multifocal motor neuropathy. Here he is 1 year later from here. Again, long thoracic nerve has not recovered. Serratus is still essentially paralyzed. You can see now recruitment of his lower trapezius. His trapezius has recovered. When we look at the coronal plane motion, you can actually see the trapezius now. Good stabilization. He locks in, and he actually has fairly good function. Trapezius has returned, spinal accessory nerve has returned, long thoracic nerve has not returned. So you can use this algorithm to track clinically how these people do. We don't always need an EMG. So again, we go through the algorithm, yes or no, we work our way through. Bottom line, if you want to simplify it, plus sign. If it's positive, it is a long thoracic nerve palsy. Flip sign, if it's positive, it is a spinal accessory nerve palsy. Dyskinesis eliminated. If you can get rid of it, it's a motor control problem, and now the therapist has to work with that patient to get rid of that and keep it out. And then if it continues, there are other things. Again, scapular muscle detachment, I have had one patient with that, a syrinx, a spinal cord syrinx, had another patient with that, had long track signs, and then multifocal neuropathy. Tumor, I guess you always have to think about it. I haven't seen that yet. So in summary, diagnosing the cause of significant scapular dyskinesis can be a challenge. Sometimes we think it's very easy, but I'm going to tell you, I showed you 15 different patients. 10 of them had the wrong diagnosis or a misdiagnosis. That's 60% inaccuracy. So again, if we use the algorithm, I think it goes up quite a bit. The algorithm is simple, improves the accuracy, and it can effectively monitor nerve regeneration through muscle activation. I'll let my friend say goodbye to you. He was waving with his scapula. He's actually using his pectoralis minor. When I saw that, I began to understand motor control issues. Thank you very much.